maxillofacial structure is an important unit of the craniofacial region, while the calvary develops a high pace in intrauterine life with the rapid development of growth of the natural structure, while the maxillofacial region develops and grows during infancy and childhood. It reaches its final shape and volume at the end of the puberty. As important as the development of the brain is in the development of the calvaria, the spaces and tissues that function in the development and growth of the maxillofacial component also play a very important role. In order for these anatomical structures to serve human beings in harmony, maxillofacial morphology develops under the influence of heredity characteristics and environmental factors. The surrounding tissues compensate and adapt to structural changes that may occur during this time. In this process, with the growth of the maxilla and mandible, the maxillofacial region is formed by adaptation and compensation mechanisms. The position of the maxilla and mandible profoundly affected in the dentition and facial soft tissues, and Engel has classified the dentition in the sagittal direction. In the following periods, with the development of cephalometric X-ray technology and applications, many lateral cephalometry analysis methods were developed on the images obtained in 2D using points, planes, and angles, which are also used in anthropology. With 2D technology, the invisible come visible, while the unmeasurable come measurable, that is calculable. This has to lead to development of more evidence-based treatment methods, CT, CBCT technology, which has been developed recently and has been used frequently in orthodontic routine, has offered the opportunity to understand morphology in 3D, mostly. This has allowed us to better understand the relationship of the maxilla and mandible with each other and the use of skull base of each. Individual variability is a fundamental principle in human biology. One of the most variable and distinguishable parts of the human body is craniofacial complex. According to Biok and Schuyler, there was anterior rotation mandible, downward movement of the lower border of the mandible, opposition to the ventral aspect trunk symphysis of the mandible, reposition at the lower border of the gonial angle, bone opposition on the posterior surface and symphysis. Backward rotation of the mandible, resorption on the lower surface of the symphysis, opposition at the posterior border of the rams and the neck of the condylar process below the gonial angle, singular symphysis of remarkable height, double chin tip soft tissue. Forward mandible rotation typically results in short face type, while backward mandible rotation results in a long face type. Vertical maxillary disability is usually associated with mild mandibular retrognathia, decrease in frontal height, decrease in the angle of the mandibular plane, and causes mandibular overclosure. If hypodogean growth is primary etiology for anterior open bite, the terms skeletal open bite or apertognathia may be used. The maxilla rotates downwards and backwards like the mandible during growth. This leads to the decrease to the sagittal projection of the chin. Such a vertical face growth pattern will tend to correlate with the posterior mandibular pattern mandibular growth. The general growth pattern of the maxilla in lateral view was described in 1955 in the first article of the implant method and later more detail. It has been shown that the entire increase in the length occurs the rear with little or no remodeling on the anterior surface. Along with the surface growth, the improvement in height occurs by oppositional growth of the alveolar process with resorptive lowering the nasal base. In addition, it was observed that the remodeling at the base of the nose changed according to direction and size of the maxillary rotation. Remodeling was the greatest anterior or posterior according to whether the rotation was forward or backward, respectively. The facial inclination of the base of the nose showed great stability regardless of the direction and magnitude of maxillary rotation. There was a strong correlation between the direction of condylar growth and the rotation of the mandible. 3 types of growth rotations are shown for both growths and individual subjects. The location of the rotation center is also given importance. Fundamentally, different ways in which mandible can rotate relative to the maxilla during growth have been described. Where the incisal occlusal is stable, forward rotation of the mandible towards the maxilla occurs around the center of the incisors. However, the main feature of compensatory adaptation to forward rotation is the forward displacement of the dental arch as a whole with respect to the base of the jaw and the forward bending of both incisors and molars. Despite the rotation of the jaw, lip and tongue function tended to maintain in functional relationship on the incisors. In response to the rotation of the mandible, the entire dental arch moved forward, resulting in compensative forward tipping of the lower molars at the base of the jaw. Such a complete adaptation creates a perfect dental arch despite the rotation of the jaw. The characteristic forward tipping of the lower anterior teeth also be seen in dental arch. If the lower incisors cannot keep up with the rotation of the jaw, crowding can be seen in the lower anterior segments. When anterior occlusion is unstable, anterior rotation of the mandible can cause basal deep bite. The rotation of the mandible towards the maxilla did not occur in the incisors. The center of the rotation was located forward back in the premolars. In the growth pattern of the face is considered as a whole, forward rotation of the upper jaw is also observed. The upper incisors do not follow this rotation but bend backwards according to the nasal Nasium cella line. 1/3 of the space for canines seen in plastic models may be due to backward tilts of the upper incisors and 2/3 of the forward rotation of the maxilla. This is a completely new aspect to developing Engel's class 2 division to malocclusion. Rotation of the mandible can be defined as the rolling of the mandible towards the maxilla about the center, moves back towards posterior molars. The chin then swings down and back with increase in anterior lower facial height. The posterior facial height becomes relatively low. Compensatory eruption in the incisors can be prevented to some extent by the position of the tongue, and open bite can be further increased. Compensatory occlusal development is also affected by differences in the prognatic development of the two jaws. Sagittal-jaw relationship during growth was evaluated, and prognatism increases more in the mandible than the maxilla. On the other hand, the change in the slope of the upper occlusal line, which is Nasium cella upper occlusal line, correlated almost significantly with the maxilla and not with the rotation of the mandible. At the lower border of the mandible, about half of the rotation is masked by compensatory remodeling in this region. About 4/5 of the mandibular rotation of the posterior border of the ramus is masked by compensatory remodeling. Rotation of the maxilla is similarly masked by remodeling of the nasal base, which remain unchanged in its inclination. A general feature of facial development is a more or less pronounced forward rotation of the face, including the two, but more so for mandible. There was a strong correlation between facial rotation and condylar growth. When we look at the conclusion, as a result, with the development of CBCT technology, we can better understand craniofacial structure, measure unmeasurable structures, and create our diagnosis and treatment plans based on evidence rather than opinion in any case. Thank you for listening to me today.